It's a great pleasure to introduce Dr. Professor Belinda George, who's a HOD of endocrinology and diabetes in St. John's Medical College, Bangalore. Madam, we have a very interesting day for you now because this topic is something which every obstetrician faces every day, how to manage diabetes in pregnancy. So kindly take over.
Thank you, ma'am. A very good morning to all of you. And at the outset, let me thank API Kochi for inviting me and giving me this opportunity. So today, we will look at diabetes in pregnancy. I will largely touch upon gestational diabetes because there are some new aspects in that. So this is the outline in which we will cover everything. So a brief history. Before insulin was discovered, gestational diabetes documentation itself was very, very less because survival was difficult. It was hard for them to conceive to begin with, and if they conceived, survival was also difficult. And the very first case series is somewhere in the 1880s, which had extremely high mortality both in mother and the baby. However, in the post-insulin era, as women with diabetes were also surviving, they were also able to conceive. So we started getting more data, and there was significant improvement in the maternal mortality rate. So if you look at this maternal mortality, you will see that from 1900s, early 1920s, 30s onwards, you can see that there's significant drop in maternal mortality. However, the fetal mortality did not change at all till about maybe 1940s. And that is when good control of glycemia started coming in because of extensive use of insulin, good control of diabetes during pregnancy. So here you can see that from 1950 roughly to 1970, the fetal mortality also has come down very nicely. And from 1970 to now again, we have seen a lot of changes in management of gestational diabetes. We now have much better markers of glycemia like HbA1c to detect pre-pregnancy diabetes. You have ultrasonography now, fetal surveillance to assess, even teratogenic effects in the fetus even before delivery. And neonatal support itself with lots of NICU care has improved dramatically. On the other side, we also have an increasing incidence of gestational diabetes because of increasing obesity and increasing pre-existing diabetes. So on one hand, we are controlling it better, but on the other hand, the burden is increasing. And if you look at the global data, you will see that Southeast Asia is among the top with regards to incidence of gestational diabetes. And in Southeast Asia, India is not behind at all. On an average, it's around 15% is the prevalence of gestational diabetes in India, which is very high. And in India, South India, of course, has the maximum prevalence of gestational diabetes. So just one or two slides on how diabetes impacts pregnancy. The whole idea of pregnancy, during pregnancy, is that there should be uninterrupted nutrient supply to the fetus. So irrespective of the mother's blood glucose always has to remain a little high so that there is continuous supply of glucose to the fetus. And the main metabolic goals of pregnancy, in the first 20 weeks, which we divide as early pregnancy, the idea is to develop anabolic stores to meet all the metabolic demands which is coming in the later half of pregnancy, and in the later half to ensure whatever stores you have done is ensuring that continuous fuel is present for fetal growth. So in patients who already have existing diabetes, what happens is in the pre-pregnancy insulin requirement will roughly be maybe about 0.8 units per kg per day, like in type 1 diabetes. And in the first trimester, there is insulin sensitivity, heightened insulin sensitivity, the requirement actually comes down. So in the first trimester, generally the glucose falls in normal women. And in the second trimester onwards, it starts increasing. And you can see in the late pregnancy, it can go up to 0.9 to 1. So what this shows is that the insulin resistance in the mother keeps on increasing throughout pregnancy. And this happens in order to ensure that the glucose is not taken up by the mother's fatty adipose tissue and muscle, and the glucose is persistently available to the fetus for continuous fuel to be given to the fetus. So coming to the complications of diabetes in pregnancy, if you look at diabetes which occurs during pregnancy, the best data we have is from the HAPO study and the HAPO follow-up study, where you can see all of these adverse outcomes definitely much worse in women who have gestational diabetes, and even long-term outcomes are worse in women who have gestational diabetes for both mother and baby. So there is no doubt that we have to intervene with regards to gestational diabetes. If there is pre-pregnancy diabetes, either type 1 or type 2, again, there is significant adverse outcome. And one of the concerns that we have, particularly when we treat patients before they become pregnant, is the risk of congenital anomalies. And if you look at the congenital anomalies, you can see that there is increases with worsening glycemia. So if you have a well-controlled patient, good glycemic control, then the risk of congenital anomaly is very minimal. In fact, it's slightly better than the population frequency. However, as the HbA1c rises, you can see that the risk of teratogenicity and congenital anomalies is much higher. Because of this, it's extremely important for us to do extensive pre-pregnancy counseling in all young women we come across. And nowadays, you're coming across a lot of young people with diabetes, both men and women. So this is an opportunity for us to intervene and tell them that they should not have an unplanned pregnancy, that pregnancy should always be planned, and ensure that the glycemic control is decent. If possible, get it as close to or as low as 6.5. If not, at least 7, or highest maybe 7.5, because you can see in that range there is not much high risk of teratogenicity. So coming to diagnosing diabetes during pregnancy, we will look at whom to screen, when and how to screen. So should we screen all pregnant women for diabetes? So if you look at the risk factors for someone to develop gestational diabetes, you can see that the ones with high odds ratio are severe obesity, prior gestational diabetes, ethnicity, and sibling with diabetes. So since all of us belong to the Southeast Asian ethnicity, it naturally means that our population is at extremely high risk for diabetes. So universal screening should be the norm in our clinical practice. So every person we see should be screened, and almost all guidelines endorse the same thing across the world. So when should we screen the patient? Again, here there is not much difference. Every guideline says at the first visit. So whichever is the first contact that the patient has with the healthcare facility, we should screen them for diabetes. And essentially, we do this particularly in the first trimester to rule out pre-existing diabetes which was undiagnosed. So that's the whole idea of checking in the first visit. However, if the first visit test is normal, then we do not leave the patient alone and say you're absolutely okay. You have to rescreen at 24 to 28 weeks to rule out the usual onset of gestational diabetes, which usually starts beyond 20 weeks of gestational age. And again, with regards to timing, there is not much disagreement or discordance between guidelines. They all say one visit at the start and then a repeat visit at 24 to 28 weeks. So how should we do the screening test? Here, of course, guidelines differ. We use the IDPSG criteria, so I will be sticking to it. Whichever criteria you use, it doesn't matter, but do screen and do not miss cases of gestational diabetes. So as per the IDPSG criteria, in the first visit, what is the screening test to use? Ideally, it should be a fasting plasma glucose and an HbA1c. You can do an OGTT if you want at this time, but most of the time if there is hyperemesis, patient is not having nausea, unable to tolerate glucose, it's not a must. We can at least use fasting plasma glucose and HbA1c. And like I mentioned earlier, what are you trying to look for in this age? At this gestational age, we are trying to look for pre-existing diabetes. So the cutoffs is what we use for non-pregnant diabetes. So if anybody has a fasting more than 126, A1C above 6.5, you can call this as overt diabetes in pregnancy, which probably was present even before the patient conceived. Of course, the current guideline says that if the fasting glucose is between 92 to 125, you can call this gestational diabetes, but this might change in the future. I will show you some data with regards to that. So if this first trimester visit testing is normal and the patient has passed the test, then you will rescreen the patient at 24 to 28 weeks to check whether gestational diabetes has set in. Here again, the cutoffs using the IDPSG criteria, you have to remember 3 golden numbers, 92, 180 and 153, that is 0, 1 hour and 2 hours. And if the patient crosses any one value, we will consider this gestational diabetes and decide to do some sort of intervention. So what is the rationale behind these random numbers? So if you look at all other criteria, whether it's the old WHO criteria or DIPSI criteria, majority of them came from old data which looked at the prediction of this particular patient developing type 2 diabetes in the future. Which is why the IIDPSG criteria, which is based on HAPO findings, is a little different because that has looked at the perinatal outcomes. So if you are treating the patient for 9 months during pregnancy and your target is to prevent perinatal morbidity and mortality, then this is the best data that we have. So I'll just tell you quickly about HAPO and how we arrived at these numbers. So HAPO was a study, multi-centric international study, which looked at 25,000 plus women. And what they did was they did OGTT at 24 to 28 weeks at 0, 1 and 2 hours. And they studied 4 major parameters: birth weight, neonatal hypoglycemia, COD, C-peptide, and utility of cesarean section. And if you look at the findings, you will see that all of the 4 parameters continue to rise as the glucose goes up. So higher the glucose, higher the adverse outcome. Now, if you want to have a cutoff for a diagnostic criteria to say that this patient has GDM at this level of glucose, you need something called the inflection point. So this is an example of the inflection point. This is how we laid down the original criteria to diagnose diabetes. Because you can see at one particular point of glucose, suddenly the risk of diabetic retinopathy rises. So it's very easy for us to come to that conclusion. But if you look at the graph that we got in HAPO, there is no such inflection point. It is a continuous positive independent association of adverse outcomes and maternal glucose. But of course, in clinical practice, you and I need some number to say above this we will intervene and below this we will say it is okay to watch. So that is the whole reason why this committee was formed, the IIDPSG group, and their job was to define gestational diabetes based on the HAPO findings. So they decided we will use an odds ratio of 1.75. So based on the odds ratio of 1.75, you have your 3 glucose values, meaning if the patient crosses 92, 180 or 153 on OGTT, then the odds of developing all adverse outcomes is roughly 0.75 times higher than patients who do not have the same risk. So this is the scientific rationale behind using this. It doesn't mean that at 90 there is zero risk. Even at 90, which is why sometimes we see even patients who have normoglycemia will end up developing maybe macrosomia or LG babies. So because it is a continuum. So this is the algorithm that we currently use. At first visit, we do universal screening, at least FPG and HbA1c, to diagnose overt diabetes or pre-existing diabetes. If this test is normal at that time, then we will re-screen at 24 to 28 weeks using OGTT. And here we use the IIDPSG criteria, which is 92, 180 and 153. And here, if you have a patient who has do not have diabetes at 24 to 28 weeks, but has a lot of risk factors, had PCOS in the beginning, has acanthosis nigricans, has family history of diabetes, and maybe even previous gestational diabetes, you can re-screen this patient at, let's say, 30 or 32 weeks, just to be sure that you're not missing out on gestational diabetes. The last group, where the fasting is not completely normal, is between 92 to 125. Currently, we call this early gestational diabetes. That is the term we have used for this group, and we actually treat them as gestational diabetes. We keep them on close follow-up and start giving lifestyle changes followed by pharmacological intervention if necessary. So this is a trial which looked at, which is called the TOBO GM study, which looked at treatment of early gestational diabetes. And surprisingly, what they found was 30% of patients who were diagnosed as early GDM based on first trimester actually had normal OGTT at 24 to 28 weeks, even without any intervention, because here they randomized them to either receive intervention or not receive intervention, which was a surprise finding, which means we are unnecessarily diagnosing a lot of women with early GDM and intervening when maybe they would have it was just a one-off finding and maybe they would have reversed to normoglycemia later in pregnancy. And here in TOBO GDM, they found that early intervention, there was some difference, particularly driven by the neonatal respiratory distress, where because of which they concluded that there is modest increment or benefit in treating early GDM. And if you look at the subgroup analysis, you will see that women who had higher glycemia which means glucose values above maybe roughly around 10, so 95, 190 and 163. If it crossed these values, they are the ones who had maximum benefit from early intervention. This is why I told you that the guidelines might change. And if you look at those values, it sort of falls to those odds ratio of 2. So definitely higher glycemia, there is higher risk of adverse pregnancy outcome. But at least in early gestational diabetes, earlier since we did not have a proper cutoff or data, we were using the same as IDPSG criteria, but now with the new data, it is likely that the guidelines in future might change with regards to early gestational diabetes. Now, briefly about management. Of course, the most important thing is that you have to monitor, because sometimes they only require lifestyle changes, because according to the criteria, even one abnormal value becomes GDL. So sometimes just lifestyle changes alone is enough to keep the glycemia under control. But remember, like I said, it evolves over time. It's going to get worse throughout pregnancy. So you have to monitor strictly throughout till delivery. And so SMBG or that is self-monitoring of blood glucose or continuous glucose monitoring is essential. If you want to start pharmacotherapy, if your glucose control is not achieved with LSM, lifestyle changes, then insulin is a standard of care and the most preferred agent. Of course, we can use metformin because metformin is preferred better by the patient. And no other OHA can be used. Only metformin and insulin is ideally can be used in pregnancy. In women with type 1 diabetes, we will be continuing the same insulin. In women with type 2 diabetes, if there are other agents, ideally before conception, we should switch over to metformin and insulin, and then you can continue both of them throughout pregnancy. And also, if the patient has gestational diabetes, do not forget to rescreen them at 6 weeks after pregnancy. So I will not spend too much time on medical nutrition therapy, but the basic funda is that you give them frequent meals, because like I said, in pregnancy there is accelerated starvation, so you do not want long periods of fasting. So small frequent meals is what is preferred. With regards to physical activity, again, if someone is very physically active, they can continue to do that activity without any harm. However, if somebody is fairly sedentary and has developed gestational diabetes and you are asking them to exercise, then we do not have to start with vigorous exercise, because that might be detrimental. Even simple walking is enough. Walking after every meal has found to have significant reduction in post-meal excursions of glucose. So with regards to once you have decided, okay, this patient has gestational diabetes and I'm going to start treating, then you need targets. So you need to remember these 3 numbers, because this is what you have to achieve. All fasting or pre-meal glucose should be less than 95. If you're monitoring using a 1 hour value, the cutoff is 140. But if you can monitor either with pre-meal and 1 hour post-meal, or pre-meal and 2 hours post-meal, and whichever cutoff is applicable, you have to use. So 95 and 120, if you remember, that's also good enough. Monitor glucose 3 times post-meal, post-breakfast, post-lunch, post-dinner, and fasting. So with regards to pharmacotherapy, yes, like I mentioned, insulin is the preferred agent. Glyburide was used in the past, which is glibenclamide, and metformin is now gaining popularity. All insulins are safe except glargine and glulysin. Most of the others have been approved in pregnancy. Earlier we used to use only regular insulin and NPH insulin. But now, after the analogs have received approval for the last decade or so, we're very comfortable using rapid-acting analogs and a basal insulin like either detemir or degludec. But the most important thing, like I mentioned, is monitoring. Without monitoring, we will not achieve glycemic targets. And if you do not achieve glycemic targets, the baby is going to be big and have adverse outcomes. So metformin, of course, is becoming very popular these days, and patients always prefer an oral to an injectable. But the main drawback is that, number 1, sometimes because of gastritis, patients tend to vomit. Number 2, metformin alone rarely is sufficient to control blood glucose. At least 50% of treatment failure is seen if you're trying to use metformin alone. So usually we can use it as an adjunct to insulin. There is some concern about metformin because it does cross the placenta and the fetus is exposed to it. And these are 2 studies which has followed up offspring who were exposed to metformin in gestation. And those numbers are very, very less. There is some concern about increased adiposity at much later life. But however, during pregnancy and throughout perinatal outcomes, so far metformin has given us only good results. So I will skip the OG in pregnancy. So coming to delivery, we can wait till term for all patients with gestational diabetes or pre-diabetes in pregnancy. There is no need to hurry in all uncomplicated cases. But if there are some concerns, we'll at least wait, try to wait beyond 37 weeks, and then the obstetrician will plan whether an early delivery is required or not. If the patient is going for labor, we would prefer to give both insulin and glucose simultaneously, particularly in women who have type 1 diabetes to achieve, because your target glucose is very, very narrow range, 70 to 120, 72 to 126. So in order to maintain that, sometimes if we give continuous infusion of glucose, it may not be enough. We might have to add glucose in the other arm as well. If it is gestational diabetes, immediately after delivery, you can stop all medications, monitor blood glucose for next 2 to 3 days, and decide whether any other intervention is needed or not. If it is pre-existing diabetes, cut down the insulin doses, because requirement will be much, much lesser. Of course, encourage breastfeeding because it has positive outcomes in glycemic control as well. So just one slide on baby with infant born to a diabetic mother. The main concerns are, of course, macrosomia, birth injury, shoulder dystocia, and hypoglycemia. So we have to monitor the child for hypoglycemia. If there is any doubt, we can shift to an ICU. Otherwise, an uncomplicated pregnancy, baby should be kept next to the mother. These are other complications which are very well known in patients with diabetes. So it's important to keep an eye out and watch out for these complications, and if necessary, take the appropriate intervention. Lastly, do not forget, in cases of gestational diabetes, that they will require a follow-up anywhere between 4 to 12 weeks when they come back. Screen them with an OGTT. And if that OGTT is normal, they have to be rescreened every 1 to 3 years, because their risk of developing type 2 diabetes in their lifetime is as high as 60%. So this is a golden opportunity and a window for us to intervene and either stop the progression or at least catch them early. So in conclusion, universal screening at first visit and 24 weeks is the norm. Early gestational diabetes, yes, it's important that we screen them, and the guidelines may change in the immediate future, but we identify those who will benefit maximum from the intervention. Sometimes just lifestyle modification alone is adequate. You can add on pharmacological intervention if you're not reaching your targets. So remember, in gestational diabetes, it's all about reaching to target. If you have not achieved your target, whether they have taken insulin or any other medication, you're not going to get the benefit. And lastly, do not forget to follow up the patient after delivery at 6 weeks postpartum. Thank you.
Thank you, Doctor, for a very nice presentation. Thanks, API Kochi, for this opportunity. I'm seeing the faces of many familiar faces after a gap of several years. And I think this is a very good opportunity, and I think don't stop with the monsoon CMA, we can have the winter and summer CMAs also in future. So regarding this topic, I have one doubt, whether the metformin, which you said that it is safe in pregnancy, how long can it be continued? Majority of them require insulin at some point of the pregnancy. Once you start insulin, will you stop metformin, or will you continue till term?
So if the patient is already on metformin for, let's say, PCOS and not type 2 diabetes, then the guidelines are very clear. You have to stop it at 12 weeks post conception. If the patient has type 2 diabetes and is on metformin, then you can continue it till term, because you want metformin to be there. But in gestational diabetes, so when you diagnose it for the first time, if it's very mild gestational diabetes and we only introduced lifestyle modification and you're monitoring, if the glycemia is not very bad, then we can give only metformin. And in India, the Ministry of Health and Family Welfare has said metformin can be used beyond 20 weeks of gestation, so that is also okay for us. So there you can add, but very often, like if the patient has very high glucose on screening, let's say it was 110 fasting and the post meal was close to 180 and 200, then metformin alone is highly unlikely to get you the glycemic target that you need. So there we generally start the patient on insulin also. Adding metformin there will definitely help, because it will smoothen out the fluctuations that you see with basal bolus regimen. And also metformin has had, in the studies, has shown a lot of benefits for the mother. So preeclampsia is generally less, hypertension is less, and baby's birth weight is also, so LG and macrosomia definitely comes on with metformin. But when the patient is on metformin, it's important to monitor the fetal growth, because metformin can also cause IUG. So on metformin, if we see that the fetal AC is coming down drastically, then we take it off.
After delivery, majority of the women don't want to continue insulin, and if they are continuing on diabetes during breastfeeding, which OHAs are safe during breastfeeding? Do you recommend?
So for both pregnancy and lactation, the only two ways that are safe is insulin and metformin. So we'll counsel them. In pregnancy, our targets are very stringent. So we will not achieve it with twice daily insulin. We will have to give them 4 times insulin, like with each meal, 1 prandial insulin and 1 basal insulin. But once they deliver, the targets are relaxed. It can be like in non-pregnant women. So less than 130 pre-meal and less than 180 or 200 post-meal is adequate. And we should be easily able to achieve it with pre-mixed insulin given twice daily along with metformin.
Dr. Belinda, you have taken us very elegantly through gestational diabetes. But nowadays, I think we are seeing more women who already have a diabetes because of late marriage, early onset of diabetes. Does the same rule apply to all of them? I mean, the management, the targets, the medication?
Yes. So the difference is that, like I mentioned, even if you're catching them, even if you're seeing a young girl who is not even married but is having dysglycemia, it is a good time for you to counsel them about future pregnancy, conception, and educate them that they should not conceive and get an unplanned pregnancy. So whenever they get married, tell them to come back to you so that you can ensure that all the drugs are safe. It's not just the diabetic agents, but even the antihypertensive agents we have to take off, ACE inhibitors, ARBs if they are on it. They should not be preferably on a statin. So we can optimize your whole medication profile if it's a planned pregnancy. And if it's a planned pregnancy, we'll also ensure the A1C is good. So we'd like to switch them to insulin plus metformin even before they conceive. And once they conceive, if they've already planned it well, they can continue the same medication.
It was an excellent presentation, Dr. Belinda. It was, as you rightly pointed out, our neonatologist also sometimes says that in spite of having an excellent sugar control throughout pregnancy, sometimes the babies, in spite of having a good optimal weight at delivery, they behave like a GDM baby with all their metabolic derangements, and sometimes even with shoulder dystocia in a 3 kg baby. So most probably this is related to an early undetected GDM, probably. Do you think so? And another thing is, what about the role of exercise? In GDM, we emphasize a lot on medical nutrition therapy, which the patient usually adheres to. But exercise is something which we don't know to what extent we would like to tell them, because they are at risk for preterm labor. So what is your take on exercise, and also about this neonatal problems in a well-controlled GDM?
So sometimes even in well-controlled gestational diabetes, we see that there is macrosomia LGA, which leads to shoulder dystocia and other problems. So GDM, glycemia during pregnancy, yes, is one very strong risk factor for LGA babies and macrosomia, but there are other factors also. Like maternal obesity, previous maternal gestational diabetes, insulin resistance and PCOS in the mother, all of them are other independent factors, which is why sometimes we do see. But intrauterine, if we see that the glucose is well controlled, but the fetal AC is persistently above 95th percentile, then we do, one is we add metformin because definitely that brings down LGA risk. Second one is another thing that we can do is a modifiable, because the rest are all non-modifiable risk factors, is that to tighten the glycemic control. So usually our target, like I said, was 95 and 140 or 120 at 2 hours. So here we will bring it down to 80 or 85, and the post-meal 2 hours from 120 to 110. And there is one paper which has shown that the adverse events are better in tighter glycemic control, but we don't need to do it in all. In only those people who have higher fetal AC centile, even with good glycemic control. Your second question with regards to exercise in gestational diabetes is that if someone is very active, you don't have to tell them to de-intensify their exercise just because they've become pregnant. But majority of the time in clinical practice, they will be diagnosed with gestational diabetes, and then when you ask them, they would not have been doing any exercise during the pregnancy, because most of the time our social nature is such that you feed them more and you make them rest more. So they do the exact opposite of what they should be doing doing during pregnancy. So in such cases, it's not prudent to start very vigorous exercise after diagnosing. You can, if the patient is not at all has been doing any activity, you can start with mild to moderate intensity exercise. They can go, if they cannot do anything else, they can just walk, because even walking will have significant improvement in glycemia. In fact, we advise all our patients with gestational diabetes to walk for 20 minutes post every meal, 15 to 20 minutes, and that they do see a significant change in their glycemic expression.
Thank you for the excellent presentation. Doctor, I have a doubt. What is the level of HbA1c in the first trimester to get a medical termination of pregnancy?
So there is no level at which the guidelines say you have to terminate pregnancy. I think what we have to remember is that even an A1C of 8 or maybe 8.5, the risk of congenital malformations is as low as 10%, which means 90% of babies won't have any problem at all. And considering the kind of fetal surveillance we have today, the kind of ultrasound, because they have early anomaly scan, and even at 18, 20 weeks, again, they have a repeat anomaly scan. So I think if you counsel the patient early on, particularly if it is a precious pregnancy, monitoring them with their consent is acceptable. But if the A1C is very high, then you can tell them the risk jumps to 25%. So it is a decision taken between you and the patient whether they want to continue. Sometimes they want to take the risk and continue, and then they have normal babies. So that is the talk between the obstetrician and, or maybe us and the patient.
Okay, thank you, Dr. Belinda. Any questions from the floor?
Question to ask. Which insulin would you prefer, an analog or a conventional insulin?
If we are treating gestational diabetes, an analog is always preferred, because you want a short-acting insulin which will not act for too long and produce preprandial hypoglycemia. So if it's gestational diabetes, we always prefer, in fact, we prefer the faster-acting aspart, which has the shortest duration of action. If you're treating type 2 diabetes, it's okay to use a longer duration, longer-acting regular insulin is also fine.
Thank you, Dr. Belinda, for the nice presentation. Unlike the previous complications discussed, this is one complication in pregnancy which we have almost conquered. With a good obstetrician, good diabetologist, a good sonologist, and any neonatologist, you will be able to deliver a normal baby. Thank you for a nice presentation.
Thank you, Dr. Belinda George, for that excellent and well-structured talk on diabetes management in pregnancy.